They're all right here.
It's
Yeah, it's all right here.
Yeah, I could go there.
Yeah, Richard has it. Yeah, you can check. If you want to keep them, yeah, you can just check them. Yeah. Okay. Yeah. Yeah, come up here. Yeah.
That's what I asked.
At the end? The panelists will stay up here. The speakers are going to come. Yeah.
Flanked by experts.
Oh, really?
Can I call this flanked by experts panel?
The what?
Flanked by experts.
You're up here, so that makes you.
Yeah, right. Yeah, right there. Water?
Once you up here.
Sure. Yeah. Huh? Oh, you want here? Well, why don't you sit there? You sit there. I'll bring you. Maybe I'll just so you. Good. How are you?
Nice to see you.
Yeah, good to see you.
That too. Where should I go where I'm not too crowded?
Oh wait, no. Good. Buck? He doesn't have your slides. Can you just, you have your thing on you?
Mike has no left.
Can you double check?
Hardly any.
Do you have your thing? Maybe just give it, just load it directly there then. Yeah. Alex, is it Roche or Roque? No, what's the right way? What's your way? What do you like? Roque? Hard K. Roque.
Great. Oh, yeah. Just spoke to her the other day.
Hi, good afternoon. I'm going to go ahead and start some intro comments while we're getting our slides. So on behalf of the Clinical Trials Committee, I'd like to welcome you all to our Clinical Trials Symposium. We have a pretty innovative itinerary today, hopefully. I'd like to first kind of set the stage. Everything that goes on today is in the spirit of academic discourse, constructive criticism about trial design. And I would like to personally thank Dr. Roque and Dr. Ganji for submitting trial concepts and putting themselves up here to present a trial idea and being subjected to the opinions of 6 panel experts and me as well. So I really appreciate that. I would also welcome audience participation. So during the discussion section, if you have anything to say, please come up to the mic. It's going to be this is intended to simulate basically an NCI GI steering committee or task force meeting where a trial is presented, a concept is presented, and basically for 20 minutes discuss all the pros, cons, benefits, goods, bads, all of that. So, and then after that, we'll have 3 of the mentees who've been part of the clinical trials committee mentorship program kind of recount their experience with it. And then after that, Dr. Gholami will come up here and present the certificates for people who have completed the clinical trials webinar series and also took the little test at the end. So without further ado, let me introduce the panelists first for this. And I could spend an hour up here giving all their credentials, so I'm not going to. So we have Emily Winslow, Syed Ahmad, Mike D'Angelica, Mike Chody, Lele Elstrom, and Andy Lowy. And these are these 6, I think everyone knows who they are, but they represent lots of clinical trial experience, We have a couple NCI task force chairs here. We have multiple NCI cooperative group study chairs here, people who have run innovative trials, past presidents of the society, and people who are running trials at their own institutions. So lots of experience, and then we'll have another 6 panelists for the next one. So without further ado, I'd like to introduce our first speaker, Dr. Alexandra Ganji. Thank you again for coming and presenting your trial concept. She's the head of leads the GI tumor program and the cancer regional therapies program at Cedars-Sinai, trained at Moffitt, and I don't want to waste a lot of time with intros. So Dr. Ganji, one more time for your protocol. Thank you.
Good afternoon. Thank you guys for being here. Thank you to the HPBA and the Clinical Trials Committee for allowing me to talk to you today. I will be posing and receiving, I'm sure, lots of feedback for this phase 2 randomized placebo-controlled trial of S-adenosylmethionine, or SAMI, in prevention of oxaliplatin-associated liver injury. With respect to disclosures, the presented preliminary data has been generated with support from a career development grant from the Department of Defense. So most of the people in this room have at some point treated a patient with colorectal liver metastases. And as you know, patients with colorectal cancer will either present with or develop liver metastases at some point in their disease course. Oxaliplatin is a key agent that's used in these patients. And we know that 19 to 78% of patients are found to have sinusoidal obstruction syndrome secondary to oxaliplatin use. The degree of liver injury may affect surgical outcomes and limit the ability for surgery, liver-directed therapies, or continued chemotherapy. And I think the focus here is not really to say that as soon as patients receive oxaliplatin therapy, we're seeing them develop sinusoidal obstruction syndrome, but certainly patients are living longer, getting more therapy, more treatment, and frequently relapse and ultimately require more treatment. So if there's a way to prevent this from happening, it may allow us to treat patients longer. The mechanism of SOS development is not well understood, and there are no established preventative strategies. Next, I'd like to focus on S-adenosylmethionine, or SAMI, as we call it, and its importance in liver health. So SAMI is a major precursor for glutathione. Essentially, half of the daily methionine that you ingest is converted to SAMI, and that's done in the liver. So the liver is essentially a SAMI factory, and after a series of methylation reactions, SAMI becomes glutathione, which is a key cellular antioxidant. About half a century ago, we identified the fact that patients who ultimately developed cirrhosis or liver disease and fibrosis may have had deficiencies in methionine, ultimately leading to oxidative stress, genomic instability, mitochondrial dysfunction, and development of non-alcoholic steatohepatitis or liver cancer. What we found out about 20 years ago or so was that it appeared that pharmacologic SAMI protected the liver by increasing glutathione, preventing inflammation and fibrosis, suggesting that SAMI, if it was deficient in the liver, could cause liver injury, and if you could give patients SAMI pharmacologically, that you saw a reversal of that problem. So we wanted to see if SAMI had any kind of efficacy on chemotherapy-related liver injury. And looking at previously described models, we found a rodent model that had been described in 2013, in which mice were treated with Folfox and developed sinusoidal obstruction syndrome. So we essentially used the same model whereby mice were treated with intraperitoneal injection of Folfox once a week for a total of 5 weeks. And we treated a second cohort of mice with daily oral gavage of SAMI at 100 milligrams per kilogram for 7 days a week. These mice were started on SAMI 3 days prior to the initiation of intraperitoneal Folfox, just to make sure that they had sufficient SAMI stores. And then after 5 weeks, the mice were culled, and we collected the liver and blood for further evaluation. Here you can see essentially that SAMI protects against Folfox-induced sinusoidal obstruction syndrome. If you look at the second column, you can appreciate that in the Folfox-treated mice, as denoted by the black arrows, there's increased sinusoidal dilation. And in the Folfox and SAMI co-treated mice on the bottom, you don't really see that. Additionally, if you look at additional markers of inflammation and injury, F480 stains for macrophages and tunnel is an apoptosis stain, you can see that co-treatment with SAMI inhibited that from happening in these mice. We then looked at liver injury markers. When you look at AST and ALT, you can see again, Folfox increased AST and ALT levels, and SAMI diminished those. Additionally, previously described liver injury markers, notably SERPINE1, MMP9, CXCL1, von Willebrand factor, and TNF, were also increased when these mice were treated with Folfox, and SAMI administration either brought them back to normal levels or completely inhibited them. Most impressive was the elevation in SERPINE1, which encodes for something known as plasminogen activator inhibitor 1, which I'll talk about in a second. So plasminogen activator inhibitor 1, as the name would imply, is the main inhibitor of plasminogen activators, and it's critical for fibrinolysis. It plays a number of different roles in the extracellular matrix, migration, monocyte migration. It's an acute phase protein. It's induced by numerous cytokines, and it's overexpressed in many cancer subtypes. What we do know is that it's a biomarker of poor prognosis in many cancer subtypes, and specifically colorectal cancer, with the suggestion of worse overall survival in patients who have higher expression of PI1. So given the six-fold rise in PI1 in our mouse models and what we learned about PI1, we decided to look specifically at this. And if you look at stains for PI1, again, you can see that the FOLFOX-treated mice had increased PI1 expression, and SAMI administration essentially attenuated that just on staining. And then if you look at Western blots, again, you'll see an impressive change. You can see that SAMI co-administration diminished the PI1 expression by about 8 times. Additionally, PI1 can be measured in the plasma via ELISA. So we looked at the same mice, and plasma PI1 levels were increased in the FOLFOX-treated mice and significantly decreased with SAMI co-administration. To see if PI1 really played a role, we then treated PI1 knockouts with the same pre-established protocol and did not appreciate on histopathology any significant sinusoidal dilation or H&E staining. And additionally, there was no significant elevation in the liver injury markers with the exception of MMP9, suggesting that it either doesn't really play a role in this mechanism or it's somewhere upstream, I apologize. So based on our murine studies, we concluded that SAMI administration appears to have a protective role in FOLFOX-induced sinusoidal obstruction syndrome. The lack of PI1 protects from FOLFOX-induced sinusoidal obstruction syndrome. And lastly, that plasma PI1 levels could be a biomarker for FOLFOX-induced SOS. We wanted to take this one step further and see if this would apply in humans. As such, we hypothesized that SAMI in combination with oxaliplatin-based chemotherapy can decrease rates of sinusoidal obstruction and vascular injury. The primary objective here being to identify the efficacy of SAMI in diminishing SOS and vascular injury on histopathology. The secondary objectives being to evaluate differences in operative outcomes, such as EBL, hospital length of stay, dose reductions and treatment delays in patients receiving therapy, and then ultimately looking at the tolerability of SAMI with oxaliplatin-based chemotherapeutic combinations. Here you can see the schema, and I apologize to the panelists if it's a little too small based on the screen we're looking at, but the key eligibility criteria were that patients had colorectal cancer diagnosed. They should have stage 4 liver-only metastatic disease that is resectable. And then they have to be either oxaliplatin treatment naive or have not received therapy for a minimum of 6 months. After eligibility criteria evaluated, the patients would be randomized in a 1-to-1 fashion to either oxaliplatin-based chemotherapy alone versus oxaliplatin-based chemotherapy in conjunction with oral SAMI, which would be given daily at a total dose of 1,200 milligrams. The SAMI tablets basically come in 400 milligram capsules. Patients would take 2 in the morning and 1 in the evening for a total of 1,200. After 6 to 8 cycles of treatment, patients would then undergo surgery at the discretion of the treating surgeon. The primary endpoint would be to look at the rates and the score, the combined vascular injury score, which I'll talk about in a second, and evaluate how that changed with patients receiving SAMI as compared to not. The secondary endpoints would be EBL, length of stay, changes in treatment delays and dose reductions, and then ultimately safety and tolerability. An exploratory endpoint would be to look at plasma PI1 and see if that's a good marker for liver injury. So what is this combined vascular injury score? Most of us have heard of sinusoidal dilation or sinusoidal obstruction syndrome as defined by Rabia-Brandt, which is part of the combined vascular injury score, which allows for scoring from 0 to 13. Each of these components basically give you a certain point, and it includes sinusoidal dilation, small vessel loss or obliteration, focal hepatocyte plate disruption, PEL, nodular regenerative hyperplasia, peleosis, and veno-occlusive-like changes. The reason we ultimately decided to use this is in speaking with our pathologists, they suggested that we review this paper. It looked at chemotherapy-induced liver injury in metastatic colorectal cancer patients, where they looked at patients treated with a number of different agents. And if you look specifically, I know it's difficult to see, at the oxaliplatin-treated patients, and you look at the star that says grade 2/3 sinusoidal dilation, not too many patients were necessarily identified having strictly SOS. But if you look at the very bottom, a CVI score greater than 3 indicated oxaliplatin-induced injury. And so they felt that this was potentially a better marker, given that a combination of the score would allow us to identify more patients who ultimately had oxaliplatin-associated injury. What about SAMI? Is it feasible to use this drug, and is it safe? Well, if you were to go on and Google SAMI, you can actually go buy it across the street, probably at Walgreens or CVS, whatever it is. And it's about $42 for 60 pills. So it's been studied extensively for cholestasis of pregnancy, other causes of cholestasis, alcohol, liver disease, depression, and osteoarthritis. It doses anywhere between 400 milligrams to 2,000 milligrams given daily. The common side effects are some GI upset, sometimes anxiety and nausea. There have been no significant adverse drug-associated toxicities reported. Key inclusion criteria for patients on the study would be patients greater than 18, ECOG 0 stage 4 resectable, as we already mentioned, and then eligible for oxaliplatin-based chemotherapy would be the most important. With respect to exclusion, we would not want patients who have underlying liver disease. If they have pre-existing grade 3 neuropathy precluding use of oxaliplatin, they would not be eligible. They have HIV, they would not be eligible, and that's because pneumocystis carinii really like SAMI, apparently. And if they have a history of Parkinson's disease or psychiatric disease requiring an SSRI, there's increased rates of serotonin syndrome, given that SAMI can also result in increased concentrations of serotonin in the brain, and the patient ultimately has to be medically fit for surgery. With respect to statistical considerations, and this was challenging, as I mentioned, in human subjects, SOS occurs in approximately 19 to 78% of patients. So when speaking to a statistician, that's essentially 0 to 100% of the time, which doesn't allow them to really account for how frequently we may see this. In the Rubia Brandt article, about 54% of patients had grade 2 or 3 sinusoidal obstruction. In our treated mice, almost all of them had some degree of SOS. But if we wanted to be conservative with grade 2, 3 SOS, we essentially said that 70% of those mice had demonstrable sinusoidal dilation and ballooning. So based on historic data and our murine data, we decided that 50% was likely a good number to say that patients may or have oxaliplatin, which certainly may be an overestimation. And we felt that we can likely decrease this to 25%. As such, we felt that a sample size of 80 patients randomized 1-to-1 would achieve an 81% power. And if the SOS rate was actually lower, we could achieve an appreciable outcome with an 82% power. So I think just to bring us back to the impact and the significance, the reality is that patients with GI cancers are living longer, given the efficacy of systemic agents and locoregional therapies. Many of these patients, not only with colon cancer, but a majority of other types of cancers, are treated with oxaliplatin. And if there's a potential for improved tolerability of oxaliplatin-based therapy in these patients, then this could have a true potential impact. Additionally, it can have better improved outcomes in all patients receiving oxaliplatin-based chemotherapy, even those who may not be eligible for surgery and are getting treatment with FLOT, FOLFOXIRI, CHOP, et cetera. So with that, I would like to thank my mentors in the lab. Dr. Shelley Liu has been studying the role of SAMI in liver disease since the late 1980s. And then certainly all of my medical oncology colleagues who tolerated going through this trial at the AACR course in Vail not too long ago. I would now welcome all of your criticisms.
That's excellent. Thank you. So we're gonna systematically go through this, and I'm gonna have the panelists speak on all of this. So the first question is the question. Is this a good question to ask? Is this a needed clinical question to ask? We'll start, Dr. Lowy. What are your thoughts?
Well, first of all, really well presented. Congratulations, and I'm sure you got lots of great feedback at the course. I guess that, you know, from the question that you raised, Shishir, about is it a good question? I think that's one of the things I wanted to kind of go into, which is whenever you design a trial, especially an early trial, and especially if you're in the NCI setting, the first question that you're going to get is what happens after this trial? So let's say that your trial is successful and you see a 27% reduction in sinusoidal injury. What does that mean? How does that relate to a meaningful, I mean, we all would assume that's a good thing, but how does it relate to a meaningful clinical endpoint? Is that enough? What do we do next? Do we have to do a trial that shows a clinical? So I'm wondering about your thoughts about that, because I think that's a very, very critical question as to kind of what you do with this concept.
Thank you. Certainly an excellent question. I think, yeah, so I don't think the challenge of treating patients with sinusoidal obstruction syndrome is necessarily related specifically to those patients who have colorectal liver metastases. We're able to operate on them. We're able to do parenchymal preserving surgery. We're typically not limited by the degree of liver injury. But other patients who are receiving oxaliplatin-based therapy, especially those patients who have hematopoietic malignancies, who are receiving CHOP, I mean, that's where you know the most about veno-occlusive disease and SOS. The challenge is that the diagnosis of oxaliplatin-related injury until it's too late in its course is strictly pathologic. And so we don't have any other metric. We don't have an imaging technique. We don't have a blood-based biomarker or anything else to suggest that we can prevent that from happening. And so this was kind of the only mechanism by which we felt that we can actually get patients who are receiving this therapy to see if there is actually any difference. Is there a change? Is there a way to look further? Is there a blood-based biomarker like PI1 that could allow us to evaluate it? The cost of SAMI is about $2.10 a day for a dose of 1,200 milligrams. It's available, and if patients are amenable to taking it, and if it's going to prevent liver disease that they may have to deal with in the future or prevent them from getting additional therapy, surgery, et cetera, certainly think it could be valuable.
And any other thoughts from the panel regarding the question?
Yeah, Alex, well presented. I guess I had a similar question to Andy is, how do you know the decrease in SOS that you are looking for is actually clinically meaningful? That's the first question is, where did you get the 50% as a baseline? Where did you get the 20% reduction as a primary endpoint? And, what data supports that that's a clinically meaningful endpoint?
So, I mean, right. So in terms of the reduction, as I mentioned, in human studies, which are all retrospective and based on the pathologic review in the specimens, it goes anywhere from 19 to 78%. There's a number of studies that suggest that there could be increased morbidity in patients who get more chemotherapy with higher rates of blood loss, length of stay. In some patients, it may preclude, definitive resection if you're doing formal hepatectomies or extended hepatectomies, which we don't do frequently. With respect to how did we get the 50% rate, we essentially looked at our murine model, which obviously that is not a human, and almost 80% of them had some degree of sinusoidal obstruction, and it was decreased to about 20%. So then if we were to be really conservative and take, the one study out there where Rubia Brandt saw about 70%, but only 54% grade 2 or 3 liver injury, we essentially used 50% there and used some of the data that we had from the murine model to suggest that it would inhibit the development of SOS. It's an assumption.
Yeah, great talk again. Interesting. I do think this is an interesting study. As you mentioned, this is really going to be primarily impacting the patients not undergoing surgery, and patients who are having lung. And so one is we want the question really is this going to, as Andy's question, is this going to be relevant? I think the case you have to make for that it's a surgical trial is that you have histology automatic, as opposed to biopsying patients who start on randomizing to this and then biopsying. However, the SOD, the more impactful clinical metric, splenomegaly, thrombocytopenia, those are really the clinical criteria. So one, just to be the devil's advocate and say, why not just design a trial without surgery that just chemo patients randomized to this agent or not, and then look for splenomegaly or look for thrombocytopenia or some clinical measure.
Right.
Thoughts about that?
Sure. So in speaking to medical oncology colleagues, they didn't feel that treatment was necessarily precluded by splenomegaly or any of the other necessary liver injury markers, AST, ALT. The limitation of oxaliplatin in treatment of patients is frequently neuropathy. Actually, it really has nothing to do with the liver until you're so far out, right? So that's the reality. And so in discussing it with them, they said, the best marker that we have for SOS is pathology. So you kind of have to prove that it works because they're not going to get so sick from oxaliplatin liver injury that it's going to limit the ability for them to give the chemotherapy. There is one study that was essentially retrospective in Italy where they used historic controls of patient who received oxaliplatin capecitabine, and they took a subset of patients who they treated with 1,200 milligrams of SAMI, and they didn't have any kind of histopathologic endpoint. But they did see that about 30% of patients had less frequent treatment delays and less frequent dose reductions in their oxaliplatin dosing, and they had lower elevation of AST and ALT. We looked at a number of patients at our own institution who had been treated with oxaliplatin for at least 6 to 8 cycles, and the degree of AST, ALT elevation was not significant, but it wasn't controlled. Some of those patients received Avastin, which is thought to potentially have a protective role against oxaliplatin liver injury. So again, it's not the outcome would be, the primary endpoint would be difficult. Sorry.
Dr. Pitt, quick question.
Or comment. So, in procedure-targeted NSQIP hepatectomy, we have some relevant information. I mean, first of all, the outcomes of surgery for colorectal liver mets are much better than for HCC and for ICC in the first place. And the majority of the operations, as you suggested, are not major hepatectomies. They're more minor hepatectomies. And we actually have a variable that we call blue or congested liver in that database. Now, it's probably not, I mean, it's not picking up everything at the histologic level at all, but only 5% of the colorectal liver met hepatectomy patients have, quote, congested liver. So I would argue that that's moderately clinically relevant, and it's a much smaller percentage than your 50%. And even in those patients, to think that it will really affect something like length of stay is a big stretch.
Yeah, good. Mike, let's comment on this.
I'll just be real quick. At the risk of suggesting some answers, there is randomized data, preoperative FOLFOX versus upfront surgery. The morbidity was higher with preoperative FOLFOX. So you have a very strong rationale that this could make a difference. Whether histology is an accurate surrogate, we don't know. And I also think that you could play up, and I just don't know if there's data, maybe I'll ask you this, the long-term consequences of this. Splenomegaly, liver failure becomes a real issue, specifically in resectable patients who live a long time, a lot of times with disease.
Yeah.
I don't know if there's any data about sinusoidal obstruction syndrome and long-term liver dysfunction.
Only in the hepatopoietic stem cell in that population receiving CHOP, but not so much in surgical patients.
So let's move on to the feasibility in terms of, can this study be done in terms of the number of patients? Are these patients available? We need treatment naive patients, or is the people who have not seen FOLFOX for greater than 6 months? So Dr. Melstrom, can you comment on feasibility?
So at many of our institutions, we do combined resections up to 30% of the time. So to help your accrual in an expeditious fashion, is there a reason that you excluded combined resections in the format that we received? These exclusion criteria excluded combined resection.
We have gone back and included combined resections. So yes, good point.
Dr. Winslow?
I guess similarly on the inclusion of the exclusion of chemotherapy receipt with, you can't have received any chemotherapy within 6 months. I think just from a logistics standpoint, many patients may be initiated on treatment and referred simultaneously. So depending on your practice environment, that may significantly limit, your enrollment. And I guess the question is that worth it or not for a cycle, to not have those patients de novo before they start treatment?
So the only data we can really use is what we've seen with respect to bevacizumab, which seems to inhibit some kind of vascular injury. And we think based on the PI1 data, likely SAMI is doing something as well to alter kind of the environment whereby we're not seeing those same levels of vascular injury that are ultimately resulting in SOS. And in previous data, it looks as though bevacizumab only has an effect for a limited number of cycles and doesn't continue to have that protection over long term. So it's not that the two are comparable, but if that's accurate, then we wanted to have patients who were essentially treatment naive for a period of time.
But you're excluding Bev though, right? They cannot,
We did not exclude Bev,
they
but we
can,
should
they
exclude
can
Bev
get Bev. Okay, so
probably.
that's something to think
Yeah.
about. What are your comments about, what are your thoughts about getting treatment naive patients at centers that would actually run this trial? Oftentimes we see patients having already gotten FOLFOX. So in terms of the feasibility of that, and also one thing that comes up a lot is patient travel of coming to get FOLFOX or a standard of care drug or a drug you can get at CVS at the index institution as opposed to the community. Your thoughts about that?
Well, for purposes of the SAMI drug, which isn't very expensive, the Vitology Health, which is one of the main manufacturers of SAMI, has agreed to essentially provide drug for free. So I don't know that $2.10 is significant for a patient, but it may be. And so that might be a reason to come to the index institution. I think it's similar to the opt-in trial where we've had patients that we've tried to enroll and they don't necessarily want to come to the treating institution to do their chemotherapy. And that's been our limitation with enrollment. So that certainly is an issue, which is why we tried to be to a degree conservative, and it could certainly be an issue with accruing.
But yeah, sorry.
So one issue I wanted to ask is the heterogeneity of patients that will be enrolled. Like what's every patient's baseline SOS? And are you going to measure a pre-op biopsy of the liver prior to surgery? And if not, then, how do you know if they had any reduction or efficacy from the therapy?
Right.
Related to the chemo plus the SAMI.
Right. No, I think it's an excellent point. So again, given the concern for getting treatment naive patients, that's why we elected to include patients who have been treatment naive for 6 months. But yes, they can certainly have underlying SOS or liver injury prior to that. The best thing we have currently is imaging. One of the biggest criticisms in the AACR course was, hey, people don't want biopsies if they don't have to have them.
Right.
And so you really have to find a way to do this without that increased risk. And that's essentially where this came to. I certainly agree with you. And the initial iteration of this was all GI patients receiving any kind of oxaliplatin-based therapy. We're going to look at different markers like bilirubin, AST, ALT, PI1. We're going to biopsy pre and post therapy, and hopefully, that would be sufficient. But this is really the only way to get the one main criteria we have to say that patients have this elevated combined vascular injury score, or SOS, is pathology. We don't really have anything else.
Yeah, I mean, I think that's reasonable, and I understand that. I guess the concern I would have just is about, I would probably exclude people who've had prior, know what the washout is. And so that really introduces a major potential confounder. And even it is randomized. And so you always hope the randomization washes out a lot of these things, but it's a small trial. And I have the same concern about including FOLFOXIRI.
Right,
because that clearly is a difference. And I think that if you have a minor imbalance in there, that could really torpedo your study results. So I would probably try to make it more pure and either, it has to be kind of all those, or just, simplify it to FOLFOX. Just one quick question. I'm assuming the placebo is included just to encourage enrollment?
Correct.
Because really no other reason why you need a placebo.
So we've kind of merged into design now, talking about, no, it's perfect. It's perfect. Regarding irinotecan, Avastin, these are all things that are coming up. What about the power analysis? Are we too aggressive here, looking for a 50% reduction, Dr. Chody?
20% reduction.
Oh, 20%.
Yeah.
Sorry, 50% relative.
50% relative.
Well,
Relative.
50% absolute reduction.
Yeah.
Yeah, I mean, it's a little bit of a guess. I mean, based on animal data. I mean, so that is a challenge in the design, but you have to pick some number. And I do think it's a little bit optimistic or aggressive in order to keep your sample size down, but whatever, I think I would have picked a similar number. Just with regard to design, other questions, we talked about placebo. So who's blinded? Pathologists are going to be blinded, I hope, right?
Yes, pathologists will be
centrally reviewed and so forth.
Yes.
The patients are blinded, the surgeons are blinded,
and the surgeons are blinded.
And with regard to, there can be some heterogeneity of where SOD is within the liver. So is it just off of the specimen, the surrounding liver, or is there going to be some protocol that the surgeon will be instructed to do where biopsy or anything related to that?
Right. The
Thomas?
discussion with our pathologist was that they felt that they could get an accurate specimen with essentially a 1 to 2 centimeter margin, which is what most of us are aiming for when resecting these. They felt that that would be sufficient to determine. But yes, it's not, you don't necessarily see SOS uniformly through the liver. You're correct. So
Any other comments on design?
Yeah. I always struggle with randomized phase 2 because in a similar way, I want to know what's going to happen after this trial. I want to know what the next trial is going to be. And so I get very frustrated with randomized phase 2 trials because I think they're a very inefficient way to study a question. You can write a phase 3 trial, although that seems very premature, and with a futility rule that stops early. Or you can do this as a very simple and cheap single arm phase 2 trial, see if there's any signal at all before you go for a much bigger trial, which is also a reasonable approach. See if you can find the patient, see if it's feasible to accrue and sort out some of the histology. And I also think when you look at the histologic endpoint, blinding is one thing, but I don't know the reader, how well reader
intravariability, yeah. Right.
Thank you for the word.
Yeah.
Yes, I'm getting old. Yeah, and I think you should probably have more than one reader and see how those readings agree with each other or do not agree with each other. So,
But you
I might really consider an earlier phase single arm trial just to look at feasibility and see if there's a signal before you go for this phase 2 trial that you're not going to know how to really interpret.
You're like hurting your future by doing a randomized control trial.
No, but I think this raises it's the same question we started with. This is what happens after this?
Sure.
And I think that's really the most important aspect of all of this. Because if it's unclear, then it's really hard to know and to get excited and to pitch it,
Sure.
frankly.
Yeah.
So
So interest of time, I'm going to make sure we get a couple of the highlights here. You did say you're doing centralized review.
Mhm.
Any other thoughts on the secondary endpoints, the length of stay and blood loss in terms of major versus minor procedures, technique? Are those the proper secondary endpoints for a trial like this with the heterogeneity?
I mean, those are really not, I mean, those are just very unlikely. I would do spleen volume, platelet count, things like that, because if this is a positive trial, what you want to do is then move to the non-cancer patient and say, wow, so something like that I think would be.
yeah, and I think we don't know anything about what the effects might be. So I think an overall, I mean, like Mike alluded to, there's been data suggesting that there's more morbidity. So just overall, morbidity score, Clavien-Dindo or any other,
Sure.
to encapsulate everything that happens to the patient, because when it's a little bit of a mystery about the biology,
Right.
just want to 1 second circle
Sure,
back.
sure.
Do we know, number one, that the optimal dose of this drug, and do we know its toxicity in combination with chemotherapy, given that it has GI toxicity and you're going to be giving it with chemotherapies, which can have toxicity as well?
Yeah,
So-
we don't know its toxicity in combination with chemotherapy, though there is currently a trial at our institution looking at the utility of SAMI for patients with HCC who are being treated with TIZO and some other agents.
And you'd presumably expect it to be low, but you never know. And
Right.
a lot of times a little run-in might be a good idea just to make sure to clear the safety bar.
So then one final question for Dr. Ganji, the best mechanism to run the trial, Dr. Winslow, Dr. Mellstrom, what do you think the best mechanism is? Single institution, multi-institutional? Where's the funding come from? Is it an NIH grant? How should we run this trial?
I'll take
Or-
the easy one. I think probably too multi-institutional leaves too many holes, right? And this type of trial, I think, is best run by a handful of centers who work really closely together, 2, 3, as opposed to single center. It really depends on volume, obviously. Funding mechanism, I'll leave to others. Can I just make one quick
Sure.
thing about the endpoint? And this may have been in part a difference between what we read and what we saw, or I couldn't see quite well enough. But on the primary endpoint, it goes back and forth, I think, between a rate of SOS and a score. And it's not clear to me, like, what score correlates to a rate, and I just think it would be nice to be clear about that primary endpoint, and so people can use the number. Yeah.
Dr. Ahmad?
Yeah,
Dr.
so-
Mellstrom, Dr. Mellstrom first.
For
sorry.
the fellows and trainees in the room, when you run studies through a cooperative group, there are disease committees. So this would go through a GI committee, but then there's also committees like symptom management palliative care committee. And this study would fit nicely into that committee. And you would have, multi-institutional infrastructure to run a trial like this through a symptom control palliative care committee.
I would say you're trying to learn something here, and to do it expeditiously, 40 patients, single center, 1.5 accrual, 6 months to analyze everything. I think you'll get your answer faster. And I just have one other comment about the aims or endpoint. Is there a way to do other biomarkers? Are there other biomarkers that you can add to what you're already doing? Because this is really kind of a discovery trial.
Right.
You're really learning what's happening in humans, like metabolomics. Is there something
Right.
else that you can add to
Yeah,
enrich
so
what you're learning here?
we submitted this for a grant, and an exploratory endpoint was looking at metabolomics to basically identify if there are any other signals and potentially consider proteomics for purposes of funding for a trial. Obviously, that could be a little bit more difficult to do with the cost associated with, a fishing expedition, which is realistically what that would be. But it would certainly be a nice correlative study to do.
Excellent. Good. This last comment, we're going to switch over to the next one. Dr.
Yeah, I want to thank the panel for this. This is a great exercise, for all of us, and Alexandra having the guts to go up with a very simple trial, how easily it can be dissected out. A couple of things. You talked about the clinical relevance for liver surgery. I think it actually has clinical relevance for other aspects you mentioned, pancreas cancer, for example. Many of these patients are getting many months of oxaliplatin-based therapy, some even 6 months or more. Even though we're not doing a liver resection, if we're doing a more extensive resection with venous resection or arterial resection, some of those livers don't tolerate that clamp time. I get liver biopsies on all my patients, and there's a high degree of steatohepatitis or SOS in those, and I can predict those people who are going to have a problem. And if we could give something that may prevent that, that may have significant relevance. The main question has to do with the SAMI supplement. You showed it's available on Amazon, 50 different brands. These are not FDA approved, and even though it says 400 milligrams on the bottle, does it really have it? And there's batch to batch differences. So what are you using? Is it a pharmacy that's compounding this, or that it's what you're giving them what you think they're giving us?
We're basically working with Vitology Health, and Nature's Made has also offered to basically give free drug, and they've given us their information regarding the drug, where it's made, the bioavailability. It's 400 milligrams per tablet. It's a disulfide bond. It comes in a blister capsule. You shouldn't get the ones that don't come in a blister capsule because SAMI attracts moisture. So it's controlled for all of those things.
Excellent. So in the interest of time and respect for other speakers, I'm going to switch it up. Thank you to all the panelists. And again, thank you, Dr. Ganji, for coming up here. Part of this was also to make some introductions. So I'm sure the panelists would be happy to sit down and go into more depth. If I could have the next 6 panelists come up, I'm going to do the introductions, and Dr. Alexandra Roque, if you could come up as well. So our next speaker is going to be Dr. Alexandra Roque, talking about a therapy trial using Botox injections to prevent DGE or reduce DGE after Whipple's. And as our panelists are coming up again, thank you to the last set. That was fantastic. Our next set of panelists is equally esteemed. We have Bhaskar Krokhamp, who is running multiple trials in the Netherlands and the PI of, I think, at least 6 trials in the Netherlands. Susan Tsai, running multiple trials at her institution. Natalie Colburn, again, leading one of the research enterprise in Canada. Guillaume Martel, who's running trials at his own institution. Alice Way, involved at Memorial Sloan Kettering with all the trials there, and Jin He as well as Hopkins. So thank you all to the panelists. Without further ado, Dr. Roque.
Good afternoon. I would like to thank the panelists and the HPBA for the privilege of presenting today. So this is going to be significantly more clinical. We are presenting the intrapyloric injection of botulinum toxin A to reduce delayed gastric emptying after pancreatoduodenectomy, called the BATCH trial. I have no disclosure. So just the problem, I think all of us in this room, we've rounded on patients. They're post-op day 2, 3, 4 or more of a Whipple, and they're bloated, they're vomiting, they're nauseated, they have an NG tube, and it goes on, and you feel it's happening. So our team consists of one hospital, the University Hospital, one School of Medicine, 7 to 8 pancreatic surgeons. We have an expert radiologist running the pancreatic tumor board. And we have a Center for Outcome Research and Quality Improvement and one clinical study nurse. So the real problem is, like I said, delayed gastric emptying. It's the most common complication after pancreatoduodenectomy, represent 15 to 50% of cases, and it's a major healthcare issue, representing up to like $235K per patient. So I Googled and I used PubMed, and I found 308 publications studying delayed gastric emptying after Whipple. And if I compare, there's almost 4,600 for postoperative pancreatic fistula. So the solution that we came up with was the injection of Botox or botulinum toxin A. I won't lie to you, before doing this study, for me, Botox was that. It was cosmetic surgery, it was wrinkles, and I didn't know a lot more about it. So just a brief overview, it actually prevents the release of acetylcholine at the neuromuscular junction, and thus it actually creates flaccid paralysis. So Botox injection is not new. It's been described in other study. It's been described in other specialty. It's been described in urology for overreactive bladder. It's been described in thoracic surgery after Ivor Lewis to prevent delayed gastric emptying. And it has been proven to be safe and efficient. And they are very small studies. This one was 18 patients with 85% of improved patient. Regarding gastroparesis, it's been described as well in many, many studies, a lot in pediatric journals. But the main problem is that there's very, very few post-op patients in those studies. So what are we competing against when we want to use Botox? So the x-axis is actually how much effort you put, and the y-axis is how much value you add. So I've put prokinetics, so Reglan. It's really like not much effort, it's just a pill, but is it really working? No one really knows. We do it empirically, but we're not sure. Cannot do it in older patients. And then I've put PEG-J or G-tube. Some people do it routinely. It's a little bit more effort. You have to put it in the OR. You have to ask your GI to put it after surgery. Does it work? Well, it doesn't really prevent gastric emptying. It just helps with the symptoms. Then I've put endoluminal pyromyotomy. So it's a lot more effort. There's a learning curve. Does it work? We don't know. There's currently a randomized control trial in Germany studying it. It's called the Porridge trial. Then I've put mechanical stretching. Some people do it routinely. They just like use a clamp and stretch the pylorus. So it's very minimal effort. Does it work? Unclear. So we think that Botox is actually minimal effort. You're already in the OR, it's just an injection, and it can provide significant value. So this is another way of saying things based on the price, the invasiveness, the ease of use, and the efficacy. And we feel that Botox actually checks all the boxes. It's, yes, it is expensive, but if you actually measure how many patients you need to treat to make it worth it, it's only 10, so it's not that much. Is it invasive? Supposedly, yes, because you have to actually inject it, but you're already in the OR, you're already open, so it's not much more. Ease of use, yes, it's just an injection, and it's efficient, proven on other type of surgery. We did a power analysis with a power of 0.8. We considered a moderate effect of 0.25. And for that, we calculated that we needed 126 patients, 63 in each arms. So based on the literature review, we considered a rate of DG of 28%, and that would actually, we would consider an expected decrease rate down to 18%. So the market, it's just one center at this point. So last year, when I was a fellow, we did 320 Whipple at IU, 100 were classic Whipple, and 200 were pylorus preserving. when we consider that in the US, there's about 9,000 Whipple a year, I considered, and I may be wrong, but that 2/3 roughly were pylorus preserving. That would be 6,000 Whipple per year in the US. And if we translate that in a financial study, that's 1.2 million loss for IU based on DGE, and that's 36 million in the United States. So the strategy at this point, just one center, an academic medical center, all patients who underwent pylorus preserving pancreaticoduodenectomy for any indication. The exclusion criteria are pretty easy. Children allergic to Botox for whatever reason, or patient refusing to get Botox. And then we would actually randomize patients. And this is a little bit different than what I had submitted initially because we revised it many times. So I had initially submitted in the abstract that it would be randomized between stretching and injection of Botox. But because we feel that everybody should be blinded, including a radiologist, that would be an information that they could find on the post-op report and all that. So we decided to do double-blinded first. So patient will be randomized 1-1 in the operating room between intrapyloric injection of Botox, 200 units, 30 milliliters, or injection of 30 milliliters of normal saline, so just a placebo. And then the results. So the primary endpoint would be the rate of DGE in percentage. It will be determined on imaging. We've decided on post-op day 3 instead of post-op day 5 that we had initially went for, just because we feel that some patients are actually almost going home on post-op day 5 and that would be useless. The radiologist will be actually blinded to what type of injection was done. And secondary endpoint are just the standard one, the 90-day mortality, the complication rate, the length of stay, and the type of gastroparesis symptoms they have 4 weeks at the post-op visit. So I want to mention that I had a long discussion with radiology about how to measure delayed gastric emptying. So everybody, all the radiologists told me you need to do a gastric emptying scan. So I was like, okay, but it's expensive. You have to exclude patients that have a blood glucose over 200, and after Whipple, that's kind of common. You have to stop opiates at least 2 days prior, which would be post-op day 1, so almost never happening, and it's twice the price of an upper GI. The benefit of the scan was that there's a formal definition of delayed gastric emptying. But based on the price and based on all the cons that I mentioned, we went for an upper GI. The stats are going to be fairly easy, nothing earth-shattering, just chi-square and t-test to compare the two groups, Botox versus placebo. The budget, it was just to be thorough, so it would be $180,000, including salaries for the clinic nurse, for the PI, and most of the finances would go towards the upper GI or towards the Botox. So 80 for each. And the milestone, so based on our volume, we feel that we could accrue patient in about a year to a year and a half. That would allow 6 months to provide to actually work on the statistics, paper, publication, presentation. That's all for me. Thank you.
Excellent. So we're going to go through the same format in terms of the question. Is this a relevant question, Guillaume?
Thank you. I thought it was a very interesting proposal, very original, and addressing a problem that's really meaningful for pancreas surgeons. I think if you tweak trial, and we can talk about what that means, that this could be a useful trial to run. So I was supportive of that part. Yeah.
Natalie, your opinion in terms of from a health services research standpoint, is this a question that we need to fix?
I think definitely. I think it's, we have lots of patients who stay in the hospital. Many times we know there's a leak. We know why the stomach's not emptying, but a lot of times you don't. And you're right, you throw Maxaran or Reglan or something else at them and erythromycin maybe, and nothing works. And they sit there for a very long time. They cost a lot of money. I thought the numbers for the pylorus preserving were interesting because I don't know that we see that many patients. I think
Okay.
it's very region specific. And there's some regions that have high uptake, where I trained as a resident, high uptake, fellow, very low uptake. So it may not be that high.
Okay.
So let's, people think, anyone opposed the question? Or everyone pretty much thinks?
Well, I mean, I think it's a very novel therapy. In terms of relevance for someone who does not do pylorus sparing pancreatic duodenectomy, it has unfortunately isn't relevant. So that's just something that you might consider. And so that if we think, do you feel that the mechanism of DGE in pylorus sparing is fundamentally different than a mechanism in patients who have classic Whipples? Because if you think the mechanism is the same, I'm not sure Botox will help. So I just think there's a sort of a science question about it, and then also just a relevance question.
Okay.
And then from a feasibility standpoint, Susan, or you want to make a comment about the
Sorry,
question too?
I was just going to agree with that, just because I think there's a recent meta-analysis that showed no difference between delayed gastric emptying, either technique. So I think that's one thing to maybe address.
And then feasibility, is this a feasible study in terms of the number of patients she's planning to enroll?
I think that gets a little bit to your inclusion-exclusion criteria. I think there's some other things to maybe consider in terms of that, but having some experience with a single institution trial, I think it's a little optimistic in terms of the 14-month accrual to the 120 patients, even at a high volume center. But again, I think that goes maybe a little bit more to the inclusion-exclusion part of that.
Boss, what do you think? Everything's feasible in the Netherlands?
Yeah, I don't have a concern about feasibility. I mean, I think even American patients would agree to have Botox or not Botox. I just wanted to go back regarding the value. I think I like the concept, and you probably know there is a similar paper where they put Botox in the ampulla to reduce the risk of post-pancreatectomy fistula. And the pilots from Heidelberg, the results were amazing. And unfortunately, I've heard the RCT that's coming out showed no difference. Okay. But we'll see there. But I like the idea. But I think feasibility should not be a problem.
Not be a problem. Dr. Pitt, quick comment.
Yeah, maybe I missed it, but I mean, a lot of the delayed gastric emptying is really due to the pancreatic fistulas. It has nothing to do with the pylorus. I mean, how are you going to control for that factor?
Right. That's coming up in endpoints, but why don't you go ahead and answer that one now? Yeah.
So it's just to we agree that it's associated with pancreatic fistula, but it's been described that part of it is also pyloric dysfunction. So you're just going to actually improve the symptoms. You're not really going to check for the etiology of it. That's just purely symptomatic treatment.
I think the point, that's a really good one, because so from a statistical standpoint, let's say your upper GI shows delayed emptying on day 3, but they have a pancreatic leak. How are you going to, is that going to be true DGE? Because the definition of DGE is really truly in the absence of a pancreatic leak, right? So if someone has a leak post-op, do you have to, do you need to account for, actually enroll based on what you need for eligible for evaluable patients, enroll an extra 20%?
Probably.
Anyone who has a leak, exclude them from analysis, basically.
Probably.
And really kind of isolate your DGE. I think you're going to have to somehow account for the other comorbid complications.
Can we comment on that?
Yeah. So go ahead.
No, I think honestly, if you're randomizing a large enough sample, you will account for the fact that you have patients who have leaks and others that don't. I don't think is particularly relevant personally. My issue is with how you define DGE and how you're going to measure it. I don't think that's the correct way to do it. We have a definition for DGE, and this is a little bit like the story for VTE prophylaxis, where you do screening Dopplers for patients and you find asymptomatic DVTs. You should use the clinical definition for DGE and avoid the upper GIs, in my opinion, and it will all come out in the wash, and you'll find out.
Natalie, you were going to say something too?
Yeah, I wouldn't exclude patients who had a leak because, again, I think you pointed out very nicely, we haven't really studied this well enough. We don't fully understand the mechanism. We don't understand fully the interaction. I mean, we think we know the interaction between the fistula and not, but we don't all know all of that, so I wouldn't exclude them. And I agree. I think there's some other things you could do other than radiology to study. You could, and we're not coming to the endpoints part yet.
No, go ahead. Go ahead. Just, keep going.
I mean, you could measure the patient's weight, which is going to be a really good measurement of how well they're eating. And then there's validated prompts for that. Okay.
Can I say something?
Yeah.
So I think it's important to realize that the different causes of delayed gastric emptying, that will not introduce a bias, but it will dilute your treatment effect. That's the problem. So not a bias, assuming your arms are equally balanced, but it will dilute your treatment effect. So just imagine if 80% of the DGE is related to post-pancreatectomy fistula, then the Botox will not work in those. So there will be only a remaining small group of patients where you can actually have a treatment effect in. So that's going to be a power issue.
Okay.
Dr. Berman?
Yeah, Steve Behrman, Alex, great work. Just a couple of methodological questions. 30 cc's of infusion seems like a lot. Are you going to standardize how that is done around the pylorus? Number two, is there any way you're going to assess baseline gastroparesis as that might impact the postoperative care? And number three is, did you plan to standardize the postoperative feeding regimen? Thank you.
So to answer your first question, it's usually done 4 quadrants. At least that's how GI and thoracic surgery are doing it. So that would be the plan: injection in 4 quadrants, so 30 cc divided. To answer your last question, we're currently working with the MD Anderson on standardizing pathways. So the feeding treatment is going to be standardized for every patient. And your second question, can you remind me? Sorry. Oh, yeah. So I agree with you. Actually, it should be part of the exclusion criteria. People that come with gastric outlet obstruction could not be part of that study.
Actually.
Yeah, it wasn't clear to me. Is this intended as a double-blind design?
Correct.
Okay, perfect. Okay, that's really important if you're going to use any clinical endpoint. Surgeon not know.
It's actually triple blinded. The radiologist, if we go with radiology, will be blinded too.
Perfect.
So can you comment on any stratification factors that you would use in terms of your randomization? That kind of like along Dr. Berman's question of pre-op, like I know there's studies that show diabetes doesn't make a difference, but does that need to be malignant versus benign indication for Whipple, pre-op chemoradiation versus no radiation, things like that, that could potentially confound?
And probably confound with like all the factors from the fistula risk score at some point, because like you would need to like make sure that this is not.
Maybe a pre-op fistula risk score is a stratification factor, then you count for, maybe that helps to balance the groups.
Correct.
So I would just think about things like that.
Okay.
And in a limited study of 63 patients in each, you can't put 15 stratification
Correct.
factors. You're going to be limited to tops 3. So you have to really think about how to really equalize your groups.
Okay.
Any other comments on design, Jen?
Yeah, ED is a very complex question. So to stratify patient for this study, you could probably incorporate numerous factors. You know, with all the factors, you know, every faculty attending already mentioned, you also need to include surgeon factors, experience, how you do the reconstruction, anti-colic, retrocolic, you know, patient factor, BMI, pre-existing diabetes. There's just too many to be even thinking about. So, but I do think this is a very important question. It's probably appropriate for a single center study because, you know, assuming your group are unanimous using the same way to do the Whipple, to do the reconstruction, to do the ERAS pathway, it's going to be hard to go outside your institution to testing other centers because we all do things very differently. I do want to mention one point. There's several really large volume retrospective cohort study from Japan, you know, studying this phenomenon. And one thing is very clear from those studies, if you do a side-to-side anastomosis, the DGE rate will drop to single digits compared to end-to-side, you know, anastomosis. This is just literally from high volume center, one surgical approach change and change the incidence. So clearly, in your institution, you do to start, you may try, you know, modify pylorus, you know, Botox injection, whatever. But my point is that it's a very complex problem. It's going to be really hard to incorporate all those variables into one study.
Yeah. Any other comments?
Can I make another comment about the design? I I think similar to the previous study proposal, I think it makes more sense to do a single arm study and start out with maybe 30 patients, kind of a like safety feasibility idea and to learn from that. And also, I think your endpoint is an endpoint that you would choose for a single arm study, because the actual endpoint would be ISGPS, DG, B or C. But a contrast study endpoint is doesn't have to be clinically relevant, right? Okay. So I think there's a mismatch you have now between you do an RCT and you have a non-clinical endpoint. Okay. So I think you can keep the endpoint, but then do the single arm. That would be my suggestion.
And Susan, any other thoughts about the best way to run this study? Is this best as a single institution study, particularly if we say go to a single arm?
Yeah.
Or
yeah.
What do you
I think as for all the things that we discussed today, particularly the variability in the other components that may contribute to DGE, a single institution study with a, hopefully a very or almost uniform approach to the surgical reconstruction elements, as well as the ERAS elements, as well as the medical, perioperative medications would be better. And I agree, a single arm study to understand whether there's a signal before moving forward with randomization, it would be good.
Dr. Sai?
Yeah, I agree with Dr. Wei. I think single arm is best just because it's a procedure. And so you want it to be as standardized as possible. I do have a question about the endpoint and whether even as a single arm, it should be a little bit later of an endpoint rather than post-op day 3, which I think is ISGPS.
Yeah, we were just concerned that we would actually miss some patients that leave on post-op day 4.
So if you change your endpoint away from the radiologic to the score,
Correct.
then it could just be at any time
Correct.
during their post-op.
Correct.
Why not use the NSQIP endpoint, which has been really well validated and is collected across the country, and then it would be very translatable. Because I think Henry's group worked really hard to develop that, and I think it's a day 7 is when it's calculated ultimately.
Yeah, I mean, we just tried to emulate what the definition was by the International Study Group, and it is what it is.
But there's a ton of data there, and it's used.
But even that's not perfect at all.
There is no
and we get
one,
questions all the
but-
time from the clinical reviewers. Well, what if they come back on day 15 and they were having a test? Is it really DGE? I mean, there's a lot of nuances to it.
Yeah.
But if you don't see anything on your contrast study on day 3 after 30 patients, then probably you don't need to bother about a trial, right?
Yeah,
that's true.
It's randomized.
Day 3 and they're all fine and they eat, despite the fact they look like they had.
You turn your mic on now.
Also isn't helpful.
Let me just comment, we did the erythromycin study decades ago, and we did a contrast study, and there were some patients who were doing beautifully, and then we gave them the contrast and they had a fistula and they got much worse. So I don't like doing studies.
Was it because of the contrast?
Yeah. I mean, they just weren't ready for that much contrast, and the radiologists, take this whole thing and drink the whole thing because we have to get good pictures. No.
And then one patient aspirates.
Alex, regarding your budget, the 80,000, your institution is willing to provide that, and does that cover? In the randomized design, you're covering pharmacy costs, placebo costs really escalate the budget. So is that really taking account all that?
Yeah. So the only question we had is if Medicare was if we go with the upper GI, which we may not after this discussion, if Medicare could consider the upper GI on day 3 as standard of care and just take care of it without having to pay for it. So that was the only question, which would decrease the budget by 80,000. So, but if we go with clinical, we save $80,000 right away. So.
Okay. All right. Well, you want one last comment?
Yeah, I have to say, I want to push back a little bit on what's been said about doing this as a single arm, because personally, I think this is a very simple, straightforward intervention with a placebo. And I think you can answer that with a very pragmatic trial where you will account for all these variabilities and techniques just by the fact that you're randomizing. And if you have a large enough sample size, this will be accounted for. There are millions of variables that affect things in surgical trials that we never account for. And the only way we can get around that is by randomizing. It's an elegant design. I would just stick with it and do the study. And if you use a definition we agree upon, which we talked about, it will work. The issue I think you'll have is that you may be underpowered, as we talked about, because I'm not even sure your event rate that you described is accurate. I think NSQIP is around 16% for Bs and Cs. And so already, if you start off at baseline event rate of 28% and you try to decrease it by 10, you may be underpowered.
All right, as this discussion illustrates that when you discuss clinical trials, everyone always agrees perfectly with each other and is a perfect design. So thank you again very much to the panelists, and we're going to have the other speakers come up, but thank you again to the panelists. Thank you to Dr. Roque. Again, the panelists, I'm sure Alex would be willing. I'm sure, Alex, if you want to speak to any of the panelists later, have more conversations. So we'll start the second part of this. I'm just going to introduce Dr. Rebecca Snyder. So the next three speakers have kind of gone through the HPBA Clinical Trials Committee mentorship program, and they're going to basically kind of recount their experience, what they've learned, what they did like, didn't like, and what they've gained. So first one is Rebecca Snyder from just recently at the MD Anderson, focusing mainly on pancreas, but I'm not going to spend a lot of time with introductions. I'll give you the mic to you, Rebecca.
Thank you, Shisher. I appreciate the opportunity to be here today and share my experience. I'll keep this brief. I know I want to give Mike and Lee an opportunity to talk about their experience as well. And some of this is really designed for hopefully those of you in the audience who are potentially interested in this program, for you to kind of understand the potential benefits of it, which I think are pretty tremendous. So I'll briefly discuss kind of how my participation in this program really led to my involvement in the Alliance Cooperative Group, as well as some leadership opportunities. I'll review some of the publications that I had an opportunity to do kind of as a result of that, and then talk about some experience I gained with clinical trial design, which I was not successful with, but I haven't given up yet. So. So for this program, we kind of were sort of divided into small groups. And so our mentor, Omid Moavin, and I were mentored by Matt Katz. And so I think for junior faculty who are at programs, maybe who don't have senior leadership in clinical trials, this program is really tremendous for that. And so we were really participating during the pandemic. So we were meeting monthly by Zoom, just the three of us, and kind of talking about ways that we could learn from Matt, and then opportunities for us to be more involved. And so Amit and I were both at Alliance member institutions and had been involved to some extent prior to this program in the Alliance Cooperative Group. And obviously AHPBA mentors are leaders in many of these cooperative groups. And so I think, this is really a nice gateway opportunity to engage in these other groups and to really become part of them, and to have an opportunity to network with non-surgeons and with medical oncologists and radiation oncologists in a collaborative fashion. And so within that, there's a lot of opportunities. And so I think, this collaboration with the HPBA and clinical trials can kind of help junior faculty navigate that. And so that can, depending on the specific group, that can involve the GI committee, which is typically the largest committee, comprised of multidisciplinary oncologists and surgeons. And then within that, there are often surgical working groups, and then additionally disease site working groups that are smaller and a little bit less formal. And so a really great opportunity to sort of develop concepts, pitch concepts, and get feedback. And then kind of throughout all this process, I also learned about opportunities to be an institutional PI at your institution. And so kind of getting to be the representative for a cooperative group study, as well as a champion for other cooperative group studies. So being like the Alliance champion for an ECOG study and reporting back. And these are kind of great sort of early opportunities, I think, to get engaged and then to have a presence and also to sort of learn about how all this works. And then that can often lead to being involved in local and institutional committees, which it did for me. So we had sort of an advisory committee for our Alliance membership. And oftentimes the clinical trials office at your institution will cover travel if you're the institutional PI on a study. And so it's great because I was able to attend the in-person Alliance meetings as well. And so through this, during the pandemic, during one of our meetings with Matt and Hamid, I brought up to Matt that, in the past, Alliance had a GI surgical working group that had kind of stopped meeting when Alliance went virtual. And he kind of said, yeah, that's right. We should start that again. And so that led to Hamid and I getting to kind of restart the surgical working group, which has been a really terrific opportunity. I think probably one of the best things or most enjoyable things I've been able to do the last few years. But within that, it's just kind of, like I mentioned, a smaller working group, but it's provided an opportunity for any members to participate and to pitch trials, and then just to form relationships. And so I've gotten to know a lot of folks in the room, in this room today, kind of through this opportunity, and it also involves opportunities to network and get to know some of the leaders in the other cooperative groups who want to share their trials or trials in concept, with our GI surgical working group. And so we meet on a quarterly basis. And so I would encourage anyone who is interested in being involved to join us, because we'd love to have you. And I think this has been a very meaningful collaborative effort. And then I'll briefly mention that kind of as a result of being involved in this, I was asked to participate very nicely by Sai and Shishir in some publications related to cooperative groups, sort of outlining opportunities for surgeons to be involved in cooperative group trials, including in pancreas cancer. And so these were both very educational for me and great opportunities academically to be involved with. And then finally, I'll mention I did propose a trial concept, which I believe I may have pitched to the GI task force that Dr. Lowy gave me some very good feedback on. And so this was a really great experience. I think, I learned a lot through the process about how these trials get developed, and also I think kind of established that this is an interest of mine. And so even though I've not been successful yet in kind of moving this forward from a trial standpoint, I get asked to review papers by many of you here that are related to the topic, which also is really educational for me. So I would just say that experience was terrific. And then I think kind of the last thing I'll mention is that the involvement in the cooperative group enabled me to get to know some really amazing people, including Eileen O'Reilly, who is just a phenomenal human being and a terrific medical oncologist. And so I had a lot of opportunities to then get to know her and work with her in a variety of ways. And so that was really beneficial. So I'll stop there. Thanks.
Thank you. We'll hold questions to the end. Next one, Leah Kewen, assistant professor, surgical oncologist, University Hospitals at Cleveland. Will discuss his experience.
Right. Just want to thank the HPBA Clinical Trials Committee, Shishir, especially for inviting me to share my experiences. I think Rebecca shared a lot of what I experienced as well. I'm going to target this talk a little bit more to what I actually, the nuts and bolts of what I went through, and hopefully convey to the audience who's interested in getting into trials, some of the things that I learned. So I have no disclosures. So just general timeline for this mentorship program. I think the application was in the fall and got accepted late 2021 or 2020, early 2021. We had an index meeting with Sai, Shishir, Matt Katz, and Becca Omid and myself. And so my institution's an ECOG institution. So I was fortunate to get Shishir as my mentor. I don't know how he feels about me as his mentee, but I could go take like an hour to thank him for all of this. But over the next year, basically, I, periodically logged into the working group, HPB working group, GI committee, surgery committee meetings, and just sort of was a wallflower and just listened to the conversations and the discussions and tried to get a sense of how things flowed, all the while developing the concept that I'll briefly show you guys. And then starting about a year ago, began presenting clinical trial concept. And I think I tallied up how many times I presented that concept. And there's some of you here who could probably give the talk better than me at this point. But a total of 21 times. Ultimately, didn't make it to the final stages, but here we are. So one of the first things I was advised by Shisher, is to find a gap in the NCCN guidelines. So we know there's no recommendations for extension of therapy in setting of localized pancreas cancer that's treated with standard approaches, which would include surgery with multi-agent chemotherapy with or without radiation. So there's some rationale for extension of therapy in the advanced or metastatic setting. We know the results of the POLO trial showed that maintenance of olaparib improved progression-free survival in patients with BRCA or PALB2 mutated metastatic pancreas cancer. And in the sporadic, non-genomically selected space, the results from Panoptimox of patients who are either randomized to alternating FOLFIRI and GEM versus 6 months of FOLFIRINOX versus 4 months of FOLFIRINOX, and then maintenance 5-FU. The maintenance 5-FU arm and FOLFIRINOX arm had improved progression-free and overall survival compared to the alternating regimen. So the maintenance concept is being studied in the localized setting now with Apollo, where patients who have completed standard therapy with somatic or germline BRCA PALB mutated localized disease are being randomized to a year of olaparib or placebo. There's some preliminary data for capecitabine extension therapy in patients who completed all standard care, and patients who received capecitabine did not meet overall survival median compared to 22 months, and relapse-free survival was 54 months compared to 14 months. So this was the rationale for my trial proposal, which took non-PALB BRCA patients who were nearing completion of all standard therapy within 3 months and randomizing them to 1 year of capecitabine or observation with the primary endpoint of relapse-free survival. And we powered the trial for hazard ratio of 0.6 or improvement to 20 months compared to a historical outcome of 12. And this got approved. So it was philosophically, the concept was pretty well supported outwardly within ECOG, the GI committee, surgery committee working group. Patient advocates approached us at the in-person meetings. And, these things take a lot of time, but Shisher knows how, Shisher really facilitated getting this to ECOG executive approval, I think in less than 6 months from when I first presented the concept. And then we presented it to the Pancreas Task Force. And at that stage, there's some surveys and you get a general idea of support. So about 80% of respondents supported the concept. However, as we were getting ready to submit this concept to GI steering committee, it was brought to our attention that there was a big lack of enthusiasm or excitement at the higher levels. And so we were advised to not submit this to the GI steering committee because capecitabine just was not exciting. And we were asked to focus on a more targeted population. So this was very frustrating. I think for those of you who've gotten, success at the cooperative group level, I think everyone would admit that it's a very inefficient, time-consuming process. And then this lack of sort of direct feedback, which would have been helpful 6 months before, could have saved time, could have focused on other concepts, et cetera. So I found that pretty frustrating, but the process taught me a ton. So where do we go? All right, so there's this Know Your Tumor registry looking at advanced pancreas cancer patients based on their genomic profiles being receiving matched therapy versus not, improvement in overall survival and progression-free survival. So this is the current concept that we're working on. sort of a single arm phase 2 design of the strategy of matched therapy extension for 1 year in that group of mutations with that group of drugs. Why? Because we have access to the drugs through the CRADA. I'm not going to give up the capecitabine concept. So I reworked the stats, and it's undergoing IRB review now at University Hospitals. So it's got case 3223 instead of EA 2223. So we're going to see where that takes us, applying for funding, et cetera. And then in addition to that, just using all of the tools I garnered, I brought this modified antibiotic pathway from Mayo Clinic into practice, and I brought it with me to UH when I was recruited there. The patients with intermediate or high fistula risk scores, soft glands, I give them 10 days of Zosyn, converted to Augmentin on discharge. So we retrospectively reviewed our outcomes with about 87 patients, lower CR pop, shorter index length of stay, shorter 90-day composite length of stay, fewer wound infections, deep space infections, IR drains, and on multivariable analysis, there's a decreased odds of by 83% CR pop. So we've now designed this trial looking at this question in a more structured way, randomizing patients in 2-to-1 fashion to extended antibiotic therapy or standard perioperative Zosyn with a primary endpoint of CR pop. So that's been IRB approved as of yesterday. So we'll be opening this trial in the next couple of, hopefully month or two. So lessons learned, good mentorship is essential and sponsorship is essential. And I can't thank Shisher enough. And I've had a lot of other help along the way from folks in this room, folks at my home institution. Another, sort of a humbling takeaway point is it doesn't really matter how good your idea is if it's not feasible. And what impacts feasibility. One thing you always have to ask is, do you have access to the drug or therapeutic intervention? How big is your targeted study population? Are there competing trials? And we're generally aware of the big cooperative group level trials, but there's a lot of IITs. It's at single institutions that may have competing interests. So you can run into general lack of enthusiasm to open a study at multiple institutions. And there's financial considerations, but ultimately the journey is the reward. Because I got a lot of tools. I think this has helped my career development, and you have to be persistent. I don't think I have to tell that audience this, but you have to keep going. So.
That's fantastic. Thank you. And last, Michael Lidsky, assistant professor, surgical oncology at Duke, will share his experience with the pump trial. And then don't leave after that. Dr. Galami is going to come up here and hand out the awards for the finishing the clinical trials webinar.
All right. Good afternoon, everyone. Shisher, thank you for the introduction and for the invitation to participate in this symposium. It's been really excellent. Over the next few minutes, I'm going to give a very brief overview of the structure of the National Clinical Trials Network, which has already been briefly touched on. And then I'll tell you from a junior investigator's perspective, how we, not I, but how we were able to get EA 2222 approved, which is a randomized pump trial. So Rebecca showed a slide similar to this, but the National Clinical Trials Network consists of these cooperative groups. And really for our space, there are 3: SWOG, Alliance, and ECOG. Within the ECOG GI space, there's somewhat of a hierarchical process where ideas are first initiated at the working group level. And you can see there are a number of different disease sites. Concepts then go to the GI committee and are ultimately chosen for application to the ECOG executive committee for approval. Once you have ECOG exec approval, you can then go to the task force, which includes representatives from all 3 cooperative groups. Ideally, you get an endorsement from the task force, though it's not required. And then concepts are discussed at the steering committee. So the steering committee disapproves 30% of trials right away. Those trials are dead in the water. And for all the trials that are reviewed and re-reviewed, only 30% are ultimately approved for full protocol submission. And what that translates into is only 4 to 5 concepts per year, which has been the unfortunate reality for the past 15 years. So I'm going to share some pearls that I learned along the way as a single investigator. This is not obviously any sort of Bible or rules to follow, but these are things I found important. So first, there's definitely some element of luck. I can't tell you how much, but this is the luck of being in the right place at the right time. So when we pitched the pump trial to the cooperative groups, the NCTN was actually prioritizing regional therapy trials in the GI space. And in the setting of a HIPEC trial that was recently disapproved and a Y90 trial that had just been published, we were pretty well positioned. There were no guarantees, of course, and it's taken a lot of work, but I think we were in a good place. And then second, it takes, if you can build momentum, take advantage of that. And right around this time, there was this renewed enthusiasm in HAI that was palpable in the community, not just amongst surgeons in this room and in our group, but also in the oncology community. So this slide demonstrates the rapid expansion of HAI in the past 5 to 10 years. The blue line and the left-sided y-axis corresponds to the number of new centers opening in any given year. The black arrow and right-sided y-axis correspond to the cumulative number of active centers in any year. And based on this wave of enthusiasm, Mike D'Angelica and I co-founded and co-lead the International HAI Consortium, which consists of over 150 surgeons and medical oncologists from nearly 60 centers around the world. This expansion of expertise has created a window of opportunity to conduct real-world multi-center trials. We also had really strong justification for why a modern-day pump trial was warranted, and specifically, as many of you know, the most recent randomized trial is over 15 years old. It compared what are now considered to be outdated regimens, and that in combination with the fact that the majority of data come from a single institution, there's ongoing skepticism regarding safety, feasibility, and efficacy of HAI outside of the Upper East Side. So these realities in combination with this renewed enthusiasm put us into this window of opportunity. For the first time ever, there are now enough centers using HAI to conduct a real-world, pragmatic, multi-center trial. So our goal was to determine if HAI plays a meaningful role in standardized algorithms for patients with colorectal liver metastases, and regardless of the answer, this will be practice-changing. So as mentioned, the cooperative group structure is shown here. And we spent about 9 months developing this trial within the consortium before we ultimately proposed it, not just to a single cooperative group, but to all 3 of them and in parallel. And while the trial ultimately landed in ECOG, we had already presented the concept to SWOG and Alliance and garnered their support, which would be really important when we got to the task force. It was also clear we needed to show support not just from the surgeons that were implanting pumps, but also from the medical oncologists. So when we submitted our application, we included signed letters from 50 surgeons, with 35 medical oncologists from the HAI consortium centers, which would also be the same centers participating in this trial. These letters not only endorsed the trial and support of it, but also indicated a commitment to placing pumps in eligible patients only on trial, which was important for the NCTN to see that this was feasible. We also met with the patient advocates and engaged them early on and got their support. And we met with them multiple times, especially when the trial design was changed, even just minimally. The point of meeting with them was to ensure that even with these trial design changes, that the trial remained patient-centric. Their advocates are on the cooperative group calls, and there's nothing more powerful than when they speak up, not just supporting a trial generically, but when they state how important the question that a certain trial is trying to answer is to the patients, and also that the patients will be eager to participate and enroll in that trial. So with all of that support in place, there's definitely an iterative process. And as you can see here, similar to the timelines that were shown, we had 16 meetings over the course of about a year. And these were the big meetings. This didn't include all the kind of offline calls and whatnot. But you can see, as mentioned, we met with all 3 cooperative groups in parallel at the committee and subcommittee level. We submitted our application to ECOG exec, got their approval, went on to the task force. We presented the trial at the ECOG spring meeting, which is a public forum, and then ultimately had a series of meetings with the GI steering committee before we had approval in September. So there's nothing intuitive about this process, and there's no indication as to what a successful trial looks like. So How did I know to set up all these meetings with the cooperative groups in parallel and to garner the support in the form of letters and to meet with the patient advocates? I guess in short, it's strong mentorship and sponsorship. So Shishir Maithel has been the secret weapon for this trial. As you heard, he's been helpful to everyone else here on the stage. And he had already navigated the NCTN process for his own trial for EA 2197. But you can see he's also the study co-chair for 5 other trials, including EA 2222. He knows the process, the politics, and he's helped us navigate every step. And then Mike D'Angelica has been not just a mentor, but also a sponsor. He's promoted me. He's been very vocal about promoting this trial and the importance of it. And I can't thank both of these enough. So what came out of all this effort, which is really the effort of the entire PUMP consortium, is this randomized phase 3 trial that's going to compare standard of care chemotherapy with or without HAI for patients with unresectable colorectal liver metastases. EA 2222 is expected to activate in the coming months, and then the real work begins. I'll make one more comment that was briefly mentioned. Going through this process does absolutely allow you to expand your network and make new friends and colleagues and collaborators from all over the country, not just surgeons, medical oncologists, radiation oncologists, clinical trialists, and also as study chair, I now have a seat at the task force meetings, which has been really informative. So in summary, the requirements for a successful randomized clinical trial in the cooperative group setting, from my perspective, does require some element of good timing or luck, but also you have to have a good idea with an abundance of support and justification that that trial is going to be practice changing. You also have to have a good implementation strategy to demonstrate feasibility. And in our case, it was the consortium. And in addition to all these things, the design, the concept, feasibility, et cetera, I think it's really important to have strong mentorship and sponsorship. There's no reason to reinvent the wheel, but rather leverage the expertise of those around you to navigate this process more effectively and more efficiently. Thank you.
Thank you. Out of respect for the next symposium coming in, I'm going to hold questions till after. I'm sure these 3 would be happy to talk to you in the hallway. But Dr. Galami, if you could come up, we can quickly introduce, if you want to say one line about the clinical trials webinar and then introduce the people who've completed it, that'd be great.
Saturday afternoon. So first of all, we really want to thank everyone, not just in the audience, but also those who really participated in this. This was a wonderful, really successful first time that we did this webinar series. And I'm here to present the certificates, but I really want to also thank Drs. Martel, Kavanagh, as well as Dr. Atrawal, to really who helped me and I'm sure obviously with getting this through. And the next year will be even more exciting. So just without further any ado, everyone just, when I call your name, please come up here, take your certificate, and then stand there right before, because we would like to take a picture with you at the end. So I'm starting with Dr. Anita Amini. Please come up here. I'm just going to keep going. Sorry, we need to get out. Dr. Andrew Fleming. Dr. Elizabeth Gleason. Dr. Neha Lad. Dr. Michael Litsky. Dr. Caitlin McIntyre. I'm going fast. Okay. Dr. Nad Narayan. Dr. Linda Q, I hope I pronounced this correctly. Dr. Oscar Roncal. Dr. Anthony Scholler. Yeah, just keep, yeah, it's for those who aren't, we will send them with love. Dr. Gerardo Vidalio, he's not here. I'll take it. Yeah. Dr. Konstantinos Zambirinis and Dr. Alexandra Rock. She's here. Yeah, okay, great. Round of applause for everyone. And for those who happen to not have taken the exam yet, you still have chances to do that exam, and we will
mail you your certificate. So please go ahead and do that because we would like to really show the excellent participation that we had in this webinar and look really forward to having an even better session next year. Thank you.
Thank you all for attending. I apologize to the next crew for a couple minutes late. Thanks.